that type of thing. So it can be quite distressing to families and caregivers to see these changes in their loved ones when, you know, previous to that it meant that is not part of their personality. And again, in dementia, these types of symptoms, signs and symptoms, probably will get progressively worse. However, in somebody with a stroke, that may improve depending on the person. Has anybody seen any inappropriate behaviours from, okay, Fallon, what have you seen?
I was looking after a patient at work and he's like known to be like inappropriate, but I was changing his pad and he was a bit like, he wanted to dance with me and then he wanted me to...
Yeah. And look, I can imagine that person before, they had dementia?
Oh, he had like
Parkinson's, yeah. Prior to that,
it was really bad.
They'd probably really be quite horrified. Or even if they had moments of, you know, lucidity, they'd really be upset to find out that that's how they behaved. Yeah. So it's challenging to learn how to manage these behaviours at times as well. So a lot of patients can be on medications such as antipsychotics that can help to regulate these behaviours and moods, but then they have other side effects as well, including increased sedation, and with that comes risks of falls, etc. Has anybody else seen inappropriate behaviours from residents or in work or out of placement? Yeah, Phoebe? What have you seen?
One of them asking my number.
Yeah, what did you say?
I was like, I can't give that to you. But like, he had dementia, but
Yeah. I guess, you know, you have to be professional, but you can sort of learn to have a little bit of a joke about it as well. Yeah. Eden, have you ever seen anything like that at all?
Just a little bit with the dementia patient.
Yeah. And it's not just the males, it can be the females as well. You know, tiny little old ladies who all of a sudden have the strength of 10 men and can be quite... I can see you smiling. Have you had experience of that? Yeah. And you wonder where they get the strength from. In hospital situations, if patients do become aggressive and if they are threatening staff, and that does happen, and they can physically assault staff, there is a protocol called a Code Black. Okay? So that's an emergency response to this type of behaviour for... First of all, as students, if you're going to areas where you have these types of patients, or even in ED, where, you know, other reasons for Code Blacks, make sure that you're safe and step back and observe how the team manages it as well. But unfortunately, it's a common occurrence, especially in areas such as medical wards, ED. I've even seen it working in the areas that I work in as well, occasionally. So, unfortunately, it seems to be getting worse and worse. Okay, so earlier this week we mentioned the FAST acronym, and this is an initiative, a health promotion to educate people about learning the signs of stroke and to activate getting a person to hospital if you suspect a person has had a stroke. So as you can see, FAST acronym stands for face. Does the face have any drooping? Are they drooling? Arms, if you ask the person to raise their arms and if they've got one arm that has normal strength and the other one they can't lift. Speech, is it slurred or confused speech? And time. So time is critical, and obviously if you're outside of a hospital you need to call 000. So time is of the essence. Now when you go out to SA Health venues, and believe me, people can have strokes. You might be looking after a patient who has a stroke whilst in hospital. I've had that happen on a couple of occasions with patients in recovery. So there is an internal emergency number that you will need to call. Private hospitals, other venues, you will be orientated to that emergency number. Okay. But as I said, time is of the essence. And as I mentioned the other day too, in the major hospitals there is a code stroke protocol for patients who are picked up and assessed by SAS, South Australian Ambulance Service, and then the nearest hospital that has a code stroke protocol is notified so that the code stroke team can present to ED to assess the patient and then put the appropriate interventions in place. So if somebody was in a smaller hospital, and there are some, like standalone day surgeries or small private hospitals, if somebody was suspected of having a stroke, they'd need to be transferred to a bigger hospital. Okay. If you're in a country hospital, they would have some kind of retrieval or transfer procedure for patients who potentially have suffered a stroke. So you would be educated about that. Is anybody going country, rural for their placements at all? Where are you going, Phoebe? That's sort of, I guess, it's a reasonable sized hospital. As far as situations like stroke, I'm not sure. They probably would transfer the patient down the metropolitan area. Caitlin, are you going somewhere? Mount Barker, again, yeah, that's small. Well, I mean, it's not really country, but I know it does come under that. But yeah, it's metropolitan, but they probably get transferred down to the Bar. Anybody else? And where are you going? Yeah, but where are you going this time for placement? You haven't got it yet? Della, do you know where you're going? Not yet? Okay. Isabel? Don't know yet? Eden? Not yet. Okay. I guess the thing is, if you're uncertain, if you're doing an assessment of your patient and you have seen any or assessed them to have changes in their neurological status, you need to escalate it, okay? And there are various ways of doing that. So whenever in doubt, just speak to your registered nurse. Just for your information, 40% of Australians can't name any of the most common signs of stroke, just getting back to this acronym. 30% of Australians recognise 2 of the fast signs of stroke, so that's from a survey done in 2021. 76% of Australians incorrectly identified signs of a stroke, confusing them with heart attack symptoms like chest pain. 80% of people would call 000 for stroke symptoms, so I guess that's good. But I would suggest that anytime you think there's any problem with a loved one or a friend, family member, whoever, just dial 000 and get them into hospital. Okay, so now we're going to look at some major medications that affect blood clotting. So just to review and understand hemostasis, when there's blood clot formation in a broken vessel. So this is just an overview of the pathway of how a blood clot is formed. So first of all, we have a damaged blood vessel. There's an injury to the vessel lining, triggers the release of clotting factors such as prothrombin. There's a formation of a platelet plug. So you can see this platelet plug here. And then we have vasoconstriction or tightening of the blood vessel. That limits blood flow and platelets form a sticky plug. And we also have the activation of thrombin here as well. We also have fibrinogen coming into play, which turns into fibrin. And you can see that with that activated platelet plug, combined with fibrinogen, we get a fibrin mesh. So fibrin strands adhere to the plug to form an insoluble clot. So that's the body's normal process when there is injury to a blood vessel. Then, of course, we have the different types of medications that affect this, what we call blood clotting or coagulation pathway. So first of all, we have anticoagulants. So what are anticoagulants? Who can tell me? What do they do?
They prevent blood clotting.
Okay. How?
Like interfering with blood's ability to clot.
Okay, so they inhibit certain clotting factors in the blood. I suggest there's some really good, if you like, looking at videos on YouTube. There's a couple of good ones on Calm Academy and also osmosis.org that explain in, I guess, relatively simple terms how this whole pathway happens, okay? So these types of medications act on different parts of the pathway to inhibit blood clotting. So some common examples of anticoagulants. Can you give me some names of some anticoagulants? Warfarin, yeah. Heparin. Any others? Apixaban, yeah, which is really quite the most popular one at the moment. Warfarin's a bit more old school. Okay, so, and there's other ones such as rivaroxaban, which apixaban and rivaroxaban are what we call direct oral anticoagulants. So how can we administer these types of anticoagulants? What are the routes of administration for these? Orally, so apixaban, warfarin, rivaroxaban usually are oral. What about heparin? How do we administer that? What type of injection? There's different types of injection routes. Any ideas? Intravenously, yes, we can actually administer heparin via infusions, but we can also give it as a push intravenously into an IV drip as well. And we can actually give heparin subcutaneously also. So what is the most common form of heparin in subcutaneous form that you will see a lot of when you go out on placement? Have you heard of enoxaparin? So patients in hospitals, because of all the complications that can come with bed rest, and those who have comorbidities such as cardiovascular disease, etc., if they've got orthopaedic fractures or have repairs of those, just as a couple of examples, they will be prescribed subcutaneous enoxaparin. When my husband broke his ankle and had surgery, he was prescribed enoxaparin subcutaneously for 6 weeks post-surgery. So I had to teach him how to inject his own enoxaparin and manage that. And quite often patients will be discharged on this medication as well. Okay, antiplatelet agents. So what do antiplatelets, why? What's the purpose of those?
They prevent platelet aggregation.
Yeah, so they have an effect on this part here where you get that clumping, that sticky plug of platelets, okay? So that's how they work in the coagulation pathway. So it makes the blood less prone to forming clots. So what's some common examples of antiplatelet medication? Aspirin, yeah. Yeah, clopidogrel, yeah. Yeah, I always used to have trouble saying that word. And another one that you might not be as familiar with is ticagrelor or ticagrelor. Okay? So you might even see patients on a combination of maybe an antiplatelet and an anticoagulant in some instances. How do we administer these medications? What routes of administration are the most common? Orally, yeah. I don't think you can administer them any other way. And apparently, if you encourage the person, if they're prescribed aspirin, if you encourage them to chew it, it can have faster action. I'm not sure why, but apparently that's the case. So, what types of patients do you think would be on antiplatelet medication? What kind of diseases would these be prescribed for? Yeah, myocardial infarctions, cardiovascular disease. What else? Peripheral vascular disease. And what have we been talking about today? Stroke. Yeah, they're the most common conditions that this type of medication will be prescribed for. Then we have thrombolytic agents. So, what are these? What do they do? They dissolve blood clots. Yeah. So these are also known as fibrinolytics. So they're administered to dissolve or break down existing clots by promoting the conversion of plasminogen to plasmin, which dissolves fibrin clots. Any examples? And you may not be as familiar with these because, again, they are administered in only certain environments for certain types of patients. They're not as common, say, on a medical ward, for example. Any names? Rectoplas, yeah. Or retiplas, I should say. Anybody else? There's also alteplase and tenecteplase. So these medications are administered via what route? Intravenously, yes, that's the only way they're administered. And these are given in acute situations. For example, what kind of situations? Myocardial infarction, yeah. Ischemic stroke, yeah. So would you administer this type of medication if you suspect somebody has had a hemorrhagic stroke? Would you or wouldn't you?
No.
Why not?
Because a blood clot would stop the bleeding.
Yeah, so you want that. If somebody's had a hemorrhagic stroke, a bleed in the brain, you want that clotting to happen, don't you? So, yeah, it would have an extreme adverse outcome. It could even be potentially fatal for somebody who's had a hemorrhagic stroke because it would potentiate the bleeding. So just again, just getting back to the thrombolytic agents, these are very, very powerful drugs and must be administered only under certain circumstances, okay? So again, you may never see these being utilised, or you might have a patient who might have come in having had a stroke and they may have been treated with one of these agents, maybe in ED or in the early stages of managing their condition. So So now we're going to have a look at these medications. So what I want you to do is just in your groups again, or if you want to work individually, have a look at these common medications which we've mentioned. Clexane is the brand name for enoxaparin, as you can see over here. Have a look or use your medication template and look at each medication, the generic, or just focus on the generic name, the drug class, indications, mechanism of action, common side effects and nursing considerations. So I'll give you, let's see, excuse me. Work on that for 10 minutes and then we can discuss it as a group. I'll just bring that up again. So you've got apixaban, warfarin, aspirin, clopidogrel, or you can choose ticagrelor, heparin and clexane. And you may have already researched these. If you have, that's great, but otherwise if not, please work on those. I'll give you a couple of more minutes and then we'll have a 10-minute break, and after that we'll go through the medications. Should have mentioned before, don't forget to look in your Lip and Cut Advisor resource, and you've also got your other pharmacological resources such as MIMS, Tiziani and your AMH to come up with your answers. Okay, let's have a 10-minute break. If you can all be back at 9:41, and then we'll go through these medications. Okay, so let's get get started with these medications. So, apixaban, what drug class does it belong to? Anticoagulant. What are the indications for it? Venous thrombosis. What else? What have we been talking about today? Stroke. What else? Oh, stroke, not stoke. Oh gosh, you're supposed to be looking this up. What other conditions would this medication be prescribed for? Myocardial infarction. Yep. Cardiovascular disease or coronary artery disease. AF. Mechanism of action. How does it work?
It stops the clotting factor called factor XA from working.
Okay, inhibits factor XA. Common side effects.
Bleeding gums.
Yep. Let's go lip and cot and have a look. What does it say? That didn't work. If you go to Lippincott and have a look, it will give you all the other types of disease conditions that this medication is appropriate for, okay? What else apart from bleeding gums can be common side effects? Okay, prolonged bleeding. So for example, if a person who's been prescribed this medication has a cut, you need to educate them that their bleeding time might be longer than usual. So they might have to apply pressure to an injury for quite a period of time, say for 5 minutes. Nausea. Anything else? What was that, sorry?
Blood pressure, like it takes blood pressure, blood heart rate.
Does it? So think about the common side effects, okay? Constipation. Whereabouts are you looking up your medications? Okay. So, what are the side effects? Just read them out.
Hypertension, high blood tension, chest pain, blisters,
What was that one? Sorry, Phoebe.
blisters,
Blisters and probably rashes. Okay. So, as I mentioned, you have to educate your patient. Avoiding. So, for example, if you've got a younger person, avoiding contact sports. I mean, obviously, if it's an old person, they're not necessarily going to be out playing footy, are they? So it's got to be relevant to their situation. What about with bleeding gums? What would you educate them about? Potential, if they've got a potential for bleeding gums, what would you educate them about when cleaning their teeth? and more gentle action when cleaning teeth. Soft bristle. Okay, what about men who shave? What would you advise them about? Yeah, avoid razors. And I mean some women, because some women do use razors, shave their legs, shave their armpits, whatever. Does this medication need to be taken with food?
It can be taken with or without food.
Okay, take with or without food. So, because patients will ask you these questions, so you need to know, okay? Also, any previous allergies, or if they've had any history of having taken this where they've had some kind of adverse outcome, okay? Aspirin, what drug class does that belong to? Antiplatelet. So what is it prescribed for? What conditions? Ischemic stroke. Yep. And I should put that there too. Acute coronary syndrome, ACS. Anything else? Or is it pretty much the same as what we have for apixaban? Okay. Cardiovascular disease. Maybe pulmonary embolism. Atrial fibrillation, myocardial infarction. Right. How does it work?
Prevents platelet aggregation.
Prevents platelet aggregation, which is clumping. Common side effects. Increased, yeah, or prolonged bleeding. Yeah. What?
Gastrointestinal irritation.
Good. GIT irritation. Yep. Anything else?
Rashes and bruising.
Rashes, bruising. Okay. That'll do. So, again, we probably need to advise the person nursing considerations here. Just copy that. So if it can potentially cause gastric intestinal tract irritation, do you think this medication needs to be taken with or without food? Is that sorry, Anne? Yeah, take with food. Because aspirin also has a non-steroidal anti-inflammatory effect, so it is classified as an NSAID. So these medications can cause damage to the mucosal lining of the stomach and the intestines. So it's best to take it with food. Clopidogrel. What drug class does this belong to? So antiplatelet. So same condition or indications as aspirin, I would imagine. How does it work? Same as aspirin? Yep. Same common side effects? Hi. We're still in the middle of our class.
Is this nutrition or diet?
No, it's nursing 2020. Thank you. And I guess you'd be doing the same things here about educating your patient. Do we take this with food or without food? Does it matter? I'm sorry?
Can you put the irritation there though as well?
Oh, yeah, okay, thank you. I'll get rid of that. Does it have that effect though? Because clopidogrel's not a non-steroidal, is it? So do we need to advise the patient about taking it with or without food? Or can it be either? So take with or without food. Right, warfarin. What type of drug class does this belong to? Anticoagulant. So this is what we call an old school anticoagulant. Indications for it? Same as apixaban? Yeah. No, I'm not going to do all that. So basically, how does it work though? Does it inhibit factor XA or does it have a different action from apixaban? Its mechanism of action. Eden, do you know? Okay, so how is it different in its action?
Vitamin K inhibits the specific vitamin K.
Okay, yes, correct. Inhibits vitamin K. So this, as far as the main thing you would have to educate your patient on warfarin is that they should avoid foods high in vitamin K. So things like spinach, for example, okay? Those green leafy vegetables. So excessive. And you would have to educate them about all these things as well, but specifically they need to have regular monitoring of their INR levels, so international normalised ratio. So regular. And, you know, probably for some of these other ones as well, especially apixaban, they would have to have regular bloods taken as well. Enoxaparin or Clexane, what type of medication it does, or drug class does that belong to? So, oh, that's not going to work for me. So it's an anticoagulant. Same as these, all these conditions. How does it work?
It's a blood thinner.
I'm sorry, Fallon.
It's a blood thinner.
Okay, let's use these proper medical terms. Instead of saying blood thinner, anticoagulant, okay, that's the drug class it belongs to. But what is its specific mechanism of action? So when we talk about mechanism of action with these types of medications, it works on that coagulation cascade pathway. So whereabouts, what part of that does it have an effect on? Maybe that's something you'll need to look up. So this is a medication that is very commonly administered. You will see in hospitals. Do you know how it is administered? I've mentioned it before. Remember the slide. That should give you a clue. So this is enoxaparin, also known as Clexane. What form of administration or what administration route would that be? Not IV. Subcutaneous. Yeah. So you may need to educate the patient on how to self-administer. And rotate different injection sites as well. Right, I'm cutting it down a bit just for time factor. What about heparin? What drug class does this belong to? Anticoagulant. And again, for all of these types of conditions, they would be similar. How does it work? What's its mechanism of action? Sorry, Ian, can you speak up a little bit louder? So it inhibits clotting factors. Again, similar side effects, I would imagine. Do you think there would be any particular nursing considerations for these medications? Quite often, patients who receive heparin are on a heparin infusion, so that means a large syringe with heparin diluted in sodium chloride, usually probably about a 50 ml syringe, will be set up. And then, depending on patient blood clotting tests, the infusion rate will be determined, okay? So that infusion will be connected to the person via an IV drip, right? So you would have to educate your patient about, the infusion, right? They don't touch it, but they would have to have it for maybe 24 hours at least. They would possibly have to have regular blood tests as well, okay? And all those other nursing considerations too about prolonged bleeding, educate them about all of those things. Essentially, heparin is usually only administered, I think, in a hospital situation. Okay? If they go home with anything, it's going to be oral anticoagulants, antiplatelets, or subcut enoxaparin. They probably wouldn't go home with heparin. Certainly not on an infusion anyway. All right, let's move on. So what is better, apixaban or warfarin? So these are two different types, as we've mentioned, of anticoagulants. This is just a visual of what these tablets may look like. And still you might see particularly some older patients who've been on warfarin for a long time being prescribed warfarin. Otherwise they may be prescribed apixaban. So warfarin is also known as Coumadin or Maravin. But again, as I mentioned before, in hospitals all medications are prescribed on medication charts with their generic names to avoid confusion and mistakes. So they come in different dosages, 1 to 5 milligrams in the Coumadin version, and 1, 3 and 5 milligrams in the Maravin version. So, as we know, apixaban is let me just show you a picture. I think we've got one of, no, we haven't got apixaban. So apixaban is a different shape. In this version, Eliquis 5 milligrams is almost like in a cylindrical shape, and the 2.5s are a round shape, pink and yellow. So So apixaban is a direct oral anticoagulant. It inhibits factor XA in that clotting cascade. One of the advantages for apixaban is usually that the person doesn't need to have regular monitoring of their coagulation blood levels. They don't need regular INR. It generally has fewer drug interactions and food interactions compared to warfarin, and there is a fixed dosage, so it makes it easier for the patient to remember. Okay. Oops, sorry, I keep clicking that. Warfarin is a vitamin K antagonist. It inhibits the synthesis of vitamin K dependent clotting factors, which are 2, 7, 9 and 10. It can be reversed with injection of vitamin K in the case of bleeding, or sometimes in the case of a person needing urgent surgery. However, if a person is prescribed warfarin and they're having planned elective surgery, they'll generally be told to cease their warfarin 7 days prior to surgery, and they might be put on a bridging anticoagulant, if that makes any sense to you. Some of the disadvantages with warfarin is that it has longer effects of bleeding, whereas apixaban is a shorter acting medication. With warfarin, as I've mentioned before, a person has to have regular blood tests called INRs. So there's a certain range that we aim for. If the person's INR is low than their normal range, then the dosage has to be increased. If it's higher than the normal range, then it has to be decreased. So the person needs to be monitored closely by their GP when outside of hospital. Warfarin's also still commonly prescribed for patients having artificial heart valve replacements as well. And sometimes you'll see patients who have pacemakers in situ who are prescribed warfarin, and some who have atrial fibrillation. Although in recent years the trend is towards apixaban because of less side effects. Right. Okay, now we're going to have a look at the case study. So hopefully you've looked at it this week. Please bring up your full case study that's available on Flow. Have you had a look at this case study? Yes, no? Yep, all right. So, Philip Boren, he's 66. He's woken up this morning and unable to move his left arm or leg, and he's been unable to speak, and he has a definite sag or droop to the left side of his face. So ambulance has been called immediately, but we don't know how long he's been experiencing these symptoms. So that's really important, remember, because as we mentioned before, it's a time factor as far as whether it's appropriate for certain types of medications to be administered, those thrombolytic medications. So standardly, if we think the symptoms have been longer than 4.5 hours, he won't be administered those medications. He's got a past medical history of hypertension. He's been on medications for the past 2 years. He's been a smoker for 20 years, but stopped smoking 2 years ago when he was diagnosed with hypertension. On assessment, he's drowsy but able to rouse when spoken to. He can nod when asked questions, but it's difficult to sort of work out if this means yes. And you'll see that sometimes in patients. You'll ask them yes or no questions, and they'll go, or they might, I like that to all your questions. So then, obviously, it can be difficult. Flaccid paralysis is present in the left arm and leg with no response to touch. So flaccid means floppy, droopy, okay, and paralysis, he can't move. And there's no response to touch, so you'd be thinking that there's a loss of sensation on the affected side. His visual fields have decreased, consistent with homonymous hemianopia. A CT scan confirms a medical diagnosis of a right brain stroke, so Stroke on the right side of his brain has resulted in left-sided complications. And he's got a clot in of the middle cerebral artery. So if you're not sure where that is, you need to have a look at a diagram of the blood supply to the brain. Now he also, with some other objective data, he's overweight and he's struggled to maintain a healthy weight since giving up team sports when he was in his 40s. So that's been over 20 years. He's under financial pressure. He has been married to his wife of 35 years, Lucy, who reports that her husband often forgets to take antihypertensive medications and will sometimes put off getting his scripts refilled or miss a medical appointment if he needs to work. She also mentions that he's had several dizzy episodes and that he had an episode of his heart racing, but said that the dizziness lasted only a short time, so it wasn't followed up. So what do you think are the immediate concerns here? So you're the second year student working in the neurological medical unit along with an RN. You've been assigned to care for Mr. Boren on day one. He's now easily roused but does not respond clearly. Seems to have difficulty forming words. Mrs. Boren has indicated that her husband would prefer you to use his first name Phil, as Lucy feels it will make her husband feel more at ease. So medical orders are as follows. Continue heparin infusion. So just remember, as I said, because we don't know how long the symptoms have been present, so we assume that it's longer than 4.5 hours. So standard protocol is that he would be commenced on antiplatelet therapy and anticoagulant therapy, which is the heparin infusion. So he's got to have clotting studies or blood taken for clotting studies every 4 hours. He's on intravenous therapy, normal saline, 1 litre over 12 hours. Does anybody know how many mils per hour that would be? How would you work that out? This is something you're going to be learning about. How would you work out the hourly rate for that drip or IBT? Any ideas? So this may be something when you do your lab intensives, you may, or certainly you'll be asked to do medication calculations as part of your 2022 topic. Well, in this instance, no, we're not going to do that. Just want you to work out the mils per hour divided by 12. So 1,000 divided by 12, okay, what does that work out to be? $83, $84 mils per hour. So this may be something that you'll be involved in, and also monitoring a patient who's on an IV like that, okay? So you need to know and check, although these days basically all IVs are set up with infusion pumps, but you might be going somewhere where they don't have a pump. So you've got to be able to work it out. He's on oxygen 4 litres via nasal prongs, and the orders are to maintain his oxygen saturations above 95%. Nil orally until reviewed by the speech pathologist. So why would that be? I did mention something earlier. See if you were listening. Why would he be on nil orally until reviewed by the speech pathologist? Sorry? Dysphagia, yeah, and? What is he at risk of if he has potential dysphagia or dysphagia?
Swallowing, choking,
He could, yeah, choke and aspiration. Yeah, yeah. So that is the standard order for anybody who's suspected of having a stroke. So then the speech pathologist needs to come and assess them for swallowing ability. What's RIB? Well, remain resting in bed. Okay. 2/24, what does that mean? Every what, sorry? No, there's no 12 there. Every 2 hours. Yeah. Again, these are the sort of abbreviations you're going to be seeing. Okay, so you need to familiarise yourself. So he needs to have 2-hourly neurological assessment and neurovascular assessment. Quite often students get mixed up between these two. So neurological is that Glasgow Coma scale assessment that I was talking about. What are neurovascular assessments? Remember when we were talking about fractures?
like movements, like physical assessment.
Well, they're both physical.
Oh, wait, that's like cardiac, the capillary.
Not cardiac. Capillary return, yeah. Colour, warmth, sensation and movement. So particularly because he's got paralysis on the left side, we need to check for circulation, which is colour and warmth, sensation, which is related to, remember that he has no response to touch, so that his sensory nerves have been affected, and movement of the affected side as well, okay? IDC, what's an IDC? Again, these are very common abbreviations. Can you say what the whole thing means? What type of catheter? Because there's different types of catheters. Yeah, an indwelling urinary catheter. So it's important to understand this because you can get an epidural catheter, which is something completely different. Okay? So that's been inserted in the emergency department. Why do you think he would need a catheter? Well, not everybody who's resting in bed has a catheter. Think about what's happened to him. Remember we talked about one of the complications? Incontinence, yeah, probably. FBC. Fluid balance chart. Okay, so why would he be on an FBC?
If he is incontinent.
Well, he's not going to be incontinent because he's got a catheter in, okay. So we need to be measuring his output from the catheter, so we need to document that. What other reasons? So obviously intake and output is very important here to monitor. Well, as we know, he is nil orally. Okay, yeah, so it's not having any oral fluids because of potential dysphagia. But what is replacing any oral intake here? IV. So you need to monitor the IV input and urinary catheter output to maintain fluid balance because he's at potential risk of dehydration until he's able to hopefully intake oral fluids. Okay. So making sure he doesn't go into a negative balance fluid-wise. So his most recent observations, his temp is 36.5, his pulse is 73 and regular, respiratory rate is 15, blood pressure is 170 over 90, SpO2 94% on room air, BGL 65 millimoles per litre. I think that's supposed to be, that's an awfully high reading. I think he'd probably be dead. I'm just wondering if that should be 6.5 millimoles per litre. Pupil reaction to light, brisk and equal. Pupil size 3 millimetres, right and left, so they're equal. Limbs, he has left arm and leg severe weakness, right arm and leg normal power. GCS of 13, his eyes are open to speech, best verbal response is 4, he's confused. Best motor response is obeys commands, normal sinus rhythm on his ECG. So with those observations, are there any that are abnormal there that you'd be thinking, need to look at this a bit more closely? Blood pressure, yeah. So we know he's got a history of hypertension and also the fact that he does miss his medications and doesn't get his script filled on occasion. Anything else? Yep. So 94% on room air, even though he's been prescribed oxygen. Maybe that needs to be put in place. Anything else that would be an urgent concern, a real priority? Okay, yeah. Left arm and left leg severe weakness, right arm and leg normal power. But we knew that when he first came in. Anything else that would be a priority that you might have to, well, you would definitely have to escalate?
What's the normal?
Yeah, it's 3 metres.
Is it injury?
I think that's the typo, 65 equal dead.
6.5.
Yeah, it's on yours is 6.5. Yeah, that's what I thought. So that's the typo. So 6.5, is that normal? Normal range? Yeah, probably. Although, you might need to keep an eye on it because he hasn't been eating or drinking, we think, for a while. So sometimes BGLs can rise in response to stress, such as these kind of events. So you might need to be doing at least BGL's QID. What's QID? 4 times a day. Yeah. Is there anything else in that data there that really stands out to you that is a priority and needs to be escalated immediately? So what is the top score for a Glasgow Coma Scale assessment? What's it out of? 15. What's his GCS score at the moment? 13. Remember how I said it is a medical emergency response criteria. If you look at the RDR, if there's a decrease in GCS by 2, that is an immediate move call. Okay? So that would be the first thing. You'd need to escalate that and the MER team will arrive and then assess and treat accordingly. So in some instances, if that continued to decrease, he probably would need to be moved to ICU, for example. All right? So this is where it's important to recognise the changes in your patient's condition and escalate. As second year students, it is appropriate for you to, if you are uncertain about anything about your patient, any changes, just get your nurse to come and check. Okay? If the person is becoming, if there's changes in conscious state, what would you do? If the person was less responsive all of a sudden, what would you do? Yeah, but in what way? Say the RN's not there and the person's becoming more and more sedate, they're losing consciousness, you can ring the emergency bell. Yeah, press it 3 times. That'll get people running, okay? Every patient should have a call bell. or in a lot of venues now, each patient will have an emergency bell on the wall behind their bed. Press that, and that will get people quick smart. Okay. And if you're with your nurse, they might just call a Merkel immediately. Okay. So it just depends on the situation. Certainly, if you have any concerns, you need to recheck your patient's vital signs again as well, just to make sure that what you have found is correct also. Okay? But you will never be left alone to manage these situations. I guess what I'm trying to say to you is recognising any changes in your patients and just escalating appropriately. All right, so just I think what we'll do is just run through a quick example of a care plan for this gentleman. So what do you think are some of the nursing diagnoses that would be appropriate for Mr. Boren? What could be a potential nursing diagnosis for Mr. Boren? I've already talked about one a bit more generically. So there's a risk of increased level or decreased level of consciousness because of perhaps an extension of his stroke, because of blood supply being reduced to parts of his brain. And this can result in increased intracranial pressure, which is the pressure inside the brain. So that can be a diagnosis for Mr. Boren. So a goal of care for him would be to recognise and report deteriorations, as I mentioned. Another goal of care would be for observations to be stable for 24 hours. So interventions, if you want to recognise deteriorations, what would be appropriate interventions for Mr. Boren? How often would you need to be monitoring him? Yeah, it might be half hourly, yeah. But standardly at least hourly, yeah. Obviously, if you're really concerned, do it more frequently. So what would you need to be monitoring? Vital signs, yeah. GCS, yeah. Okay, so any other interventions? Yeah, because we know his oxygen saturation was a bit low on room air, so what, do you think it was significantly low? So it's 94%, so what would be the appropriate way to deliver oxygen? Nasal space? Yeah, yeah. So if we had it at 2 litres, I think that was the order. And just to see what the response to that is. If it's maintaining above 95%, that's great. And that will certainly, hopefully, help with perfusion in his brain cells as well. Okay? So we don't want to risk any more damage to the neurons with hypoxia. Anything else? Okay, so if we assume he hasn't taken any medications for his blood pressure and his blood pressure is still remaining high, what do you think are going to be one of the interventions for him? What's that, sorry? Is he going to be able to take his oral meds? Now remember that he's nil orally. Okay.
Is it the nurse's job to organise the
You would have to do a referral. Yeah, that's probably part of that coordinated MDT approach. Yeah. Usually there will be a referral, but I guess I don't work on a stroke ward, but I would imagine they are notified as soon as a new patient is admitted that needs to be assessed. So if somebody's got a high blood pressure and it's not coming down to within normal parameters, so that his blood pressure systolically is in what we call the red zone. So we need to do something about that. If he can't have anything orally, what do you think is going to be the appropriate way of managing that? Okay, yes. So there's certainly intravenous antihypertensives that can be administered via his drip. But first of all, we would need to notify the doctor. Yeah, let them know what the results of your assessments are, and his blood pressure is consistently high. And we want to bring it down because of the increased risk of, if his blood pressure remains high, his stroke could possibly further extend. Okay, so that pressure in the brain will increase and put him at more risk. So then we need for the doctor to write up or prescribe a medication that can be given intravenously to bring his blood pressure down. And there are certain types of medications that can be prescribed for that. So after that medication's been administered, so you guys as second years wouldn't be able to do that, but what can you do post-administration of an intravenous antihypertensive? What would be your role there? How do you know that that medication has had a good effect?
Recheck his blood pressure.
Yeah. So you need to continue taking this blood pressure post-administration. So the effects of that medication potentially can act very quickly. So it possibly could have quite a dramatic effect in that it dramatically decreases blood pressure. Okay, so patients in that sort of situation, they might need to be on constant blood pressure monitoring, and with the automatic blood pressure machines that we have these days, we can set them up to take blood pressures frequently, 5-minutely, 10-minutely, whatever intervals you want to do. If somebody's really seriously ill, and if this person has been nerve called, they probably would be transferred to ICU anyway. But potentially if you're in an area where you don't have these resources and you've been, say for example, you're in a country hospital, small ED, you're waiting for MedStar, the retrieval team, to come and pick up your patient, this is what you need to be doing to safely monitor your patient. What else? Are there any other sort of investigations that would be necessary as part of the interventions that might need to be considered?
Just random question. What type of stroke did he have?
What do you think? Consider his history. He is overweight, 66, past smoker, hypertension,
So
ischemic stroke. Yeah. So these are the most common types of stroke that you will see, especially within that age group. Okay. Any other investigations that might be necessary? So as nurses, we can coordinate investigations. Is there any specific blood tests that he might require? Think about it. He's on anticoagulants. So what specific blood tests might he require?
complete blood count.
Yeah. But what blood investigation is specific to ischemic stroke, do you think? And the medications that he has been prescribed? you're going to be looking at the coagulation studies. Certainly complete blood examination or blood picture is necessary, and electrolytes, etc., but particularly your coagulation studies. So we want to see with his prothrombin times, maybe an INR as well, see how quickly his blood actually clots or not. Okay? He's already had a CT of his brain. He might need to have another follow-up one, or he might need to have a CT brain with angiogram as well, maybe. Who else might we need to involve in the care of this patient as members of the MDT? So we know there's nurses, there's doctors, we've talked about speech therapists. Who else as care progresses for this man? Who else might need to be involved? Physio? Yeah, as part of that sort of regaining strength, independence, rehabilitation. Who else? OT? Yeah. Pharmacist? Yeah. Review of medications and education.
Would you need like a nutrition?
Yeah, dietitian, yeah, depending on what his results are as far as if he has difficulty with swallowing and those sorts of things. Yeah. Anybody else, potentially? So it's still working, so there might still be financial pressure. Maybe a social worker. Also involving family as far as education, letting them know what's going on with the patient, updating them regularly, and as ongoing care progresses, knowing what resources they can access as well. Organisations such as the Stroke Foundation, maybe, I'm not exactly sure, but they probably have some sort of support for people who suffer from strokes and also their caregivers as well, different resources and information available. Okay. Anything else? Certainly something to also think about in the immediate term for this man is until he is properly assessed as far as swallowing, nurse him slightly head up 30 to 45 degrees. Because if he has anything in his stomach and it comes back up, if he has dysphagia, he's at risk of aspiration as well. Okay? So that will be another standard form of care for your patient. If he's resting in bed, what else would you need to be thinking of? So he's at risk of pressure injuries. So what would we need to be doing as nurses? 2 hourly, pressure area care, as we used to call it. Yeah. And he also may need some exercises because he can't move his left side. So the physio might have a plan of passive exercise or limb movement to prevent contractures. One of the risks for people who have permanent paralysis or effects of paralysis on their limbs is that they can become stiff. So to prevent that, we need to put some exercises in place until he possibly regains strength. Something else to think about, just as an adult, if you happen to go to hospitals such as Hampstead, Modbury as well, they have specific wards for patients who have had a stroke a while ago and they are receiving ongoing rehabilitation for the consequences of their stroke. So one of the main things that they really emphasise is for the patient to be as independent as possible. Okay? So just be aware of that if you have placement in any of those sorts of environments. But getting back to what we were talking about with the risk of decreased level of consciousness for this man, how would you evaluate all of those interventions? For example, doing neurological assessments and vital signs every 60 minutes. So think about your ADPI. So assessment, nursing diagnosis, planning, implementation. Then we need to evaluate the effects of the interventions. Okay? So for example, if you've been doing neurological assessments, GCS, vital signs every hour, so that you can detect changes in the patient's conditions, how would we evaluate that? Compare results or recognise when there are any deteriorations or maybe improvements. Anything else? With the medical team? Yeah. So any changes, have been reported and escalated as necessary. Okay. Right, that's enough of that. Just quickly, of course, this being the last session for the last module, are there any questions about anything you've learned throughout this topic at all that you want to go over quickly, or what you found interesting? I guess you're just glad to get it finished. But I think if I can offer any advice, for these are for all your topics, make sure you do the pre-readings, because it does seem evident to me that a lot of you aren't doing that. Okay? You need to be prepared for these tutorials. And the only way you're going to be able to do that is by being invested in the content. Now, if you want to, you can go to this link, Qualtrics. It's about the evaluation of teaching and also an evaluation of the jigsaw puzzle activities that we've used during the topic. So that was something new for this year. Did you enjoy those jigsaws? Did you find them useful for your learning? If you did, that's great. If not, well, give your opinions, okay? Because we're always looking to try new things depending on response. And if you have any other feedback to provide, please do so. Okay? So thank you for your attendance throughout the topic. I hope you've learned a lot of valuable things. You're going to have 2023 next semester, which is a follow-on, and patho and pharmacology. So you really need to have a good grounding in these concepts to be able to take on that. And if there's anything to go by last year, I think last year's 2023 topic was, I often find that students, even as third years and the beginning graduate RNs, have a very superficial knowledge of pathophysiology and even normal anatomy and physiology. And it's quite difficult to sort of comprehend why patients present with certain signs and symptoms, why they have medications, investigations, if you don't understand, okay? So I can't emphasise enough how important it is to really have a good grounding in these concepts. Anyway, that's my advice for you. I wish you all the best. Good luck with your upcoming placements. Who knows, I might see you around in the future. I might see you in 2023, because I usually teach that topic as well. Okay? Make sure that if you have any requests for extensions for your workbook, get them in plenty of time as well. If you do have any questions before you submit, please email me. Okay? Thank you everybody, and good luck. See you later.
Oh my god, it's so cold. Thank you so much.
See you later.
Thanks, Chris.
Good luck.